Good evening and welcome to Doctors on Call. I'm Dr. Alan Johns from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth, and I'll be your host for our program tonight on lower GI problems. We'll be glad to take your questions on conditions like hemorrhoids, constipation, colitis, diverticulitis, and colon cancer. The success of this program is very dependent on you, the viewer. Please call in your questions and we will do our best to address them. The telephone numbers for your questions can be found at the bottom of your screen. Our panelists this evening include Dr. Bradley Irwin, a gastroenterologist with St. Luke's Gastroenterology Associates in Duluth, Dr. Daniel McKee, a gastroenterologist with Northland Gastroenterology in Duluth, and Dr. Aaron Thackeray, a gastroenterologist with Essentia Health Duluth. Our medical students answering phones tonight are Derek Anners from Sauk Rapids, Minnesota, Paige Nelson of Emmons, Minnesota, and Melody Shepard from Lake Burton, Minnesota. And now on to tonight's program on lower GI problems. Well, Dr. Irwin, I think that we have some questions left over from last week, actually, when we had a lot of phone calls. But one person here would like to know, are there any new medications for ulcerative colitis? But maybe before we start that, what is ulcerative colitis?
Well, ulcerative colitis is inflammation that largely affects the colon. And by definition, it involves the rectum and can spread more proximally up through the colon to involve that. It falls in the family of inflammatory bowel disease, which also includes Crohn's disease. Mm-hmm. So it generally presents with diarrhea, bloody stools, abdominal pain, and it can be quite debilitating for people.
So are there some new medications for that?
Well, overall, I think probably the most exciting thing is the approval for more of the biologic therapy for ulcerative colitis. Remicade had gotten approval for ulcerative colitis about 1.5 years, 2 years ago, and now some of the other biologics are being used more aggressively in ulcerative colitis, mm-hmm. especially for pancolitis. And then the standard therapies that have been around for a long time, which include Imuran as well as mesalamine. So.
Well, thank you. Dr. McKee, we have a caller from last week who had a question from Hibbing about a serrated adenomatous type of colon polyp. So what's that all about?
Well, a serrated adenoma is a type of polyp that, as far as being serrated, that's just a histologic variant. In other words, it's an appearance that the pathologist would note. It's nothing that we would see necessarily doing our procedure, but it's something that we've noted more of recently. And serrated adenomas are can be a little more aggressive and need to be followed closely, but it's just a variant of an adenoma, which is a precancerous kind of polyp. And you know, if the gastroenterologist calls and mentioned that you had a serrated adenoma, it's just one of the variants of precancerous polyps, mm-hmm. and then they would go over with you the appropriate follow-up interval based on the size and details of what was seen under the microscope.
Okay, well, thank you. Dr. Thackeray, there's a question here, a caller from ESCO last week was wondering about the chances of diverticulitis turning into cancer, but maybe before we should ask that, what is diverticulitis?
Sure. Well, in the colon you can get little outpouchings, and mm-hmm. those are called diverticula. And when they get infected or inflamed, that's called diverticulitis. That usually presents with abdominal pain, you may notice a fever, high white count, things like that. And so that's a separate process from the typical kind of polyp to cancer sequence that we think about. Mm-hmm. So someone could certainly have both diverticulitis and cancer, but we don't think of diverticulitis leading to cancer.
Well, that's good. And diverticulitis is fairly common.
Yes, it is. Yep.
Thank you. Dr. Irwin, a caller was wondering about Gardner syndrome, wondering how often should a person have a colonoscopy if it runs in their family, and what is Gardner syndrome?
Well, Gardner syndrome is a genetic disease. It's really familial adenomatous polyposis. And these patients develop multiple polyps in their colon as well as other types of tumors throughout the body, things like lipomas and osteomas and things like that. The other big concern, of course, is developing polyps and tumors in the upper GI tract around the ampulla. Being a genetic disease, we've identified the gene that's responsible for this particular syndrome. It's the APC gene. And really, I think the question begs, you know, if you have Gardner syndrome, FAP, you probably in your family, they need to be screened for that potentially, and that would give you a lot more information as to how you would approach each individual family member, because it's very possible that they don't have that gene, in which case they fall under the same sort of risk as everybody else. Mm-hmm. But since it's an autosomal dominant disorder, it's something you really should screen for.
So that means if one person has it, everyone's going to have it in their
family?
family?
Well, not necessarily, but it's something you have to be concerned about.
Oh, okay. Well, thank you. Dr. McKee, we've got another polyp question for you here. Caller from International Falls was wondering about selenium or in fish oil supplements to prevent polyps, and maybe I'll add to that, is there anything you can take to prevent polyps?
Well, that's a great question. Is there anything you can take to prevent polyps? Probably not. I mean, there isn't anything you can take that's absolutely going to prevent polyps. Selenium doesn't prevent polyps. We used to think that being on a high fiber diet would prevent polyps. That doesn't work. So no, I mean, the short and simple answer is you cannot prevent polyps. Taking certain medications, non-steroidal anti-inflammatories, that is, medicines like ibuprofen, Motrin, may reduce the risk of polyps, but it isn't generally recommended that everybody go out there and take non-steroidals to reduce polyps. There may be, for certain people at higher risk, it might be appropriate, and it's something to discuss with your physician, but the short and simple answer is there is no surefire way to prevent polyps.
Thank you. Thank you. Dr. Thacker, we have a caller from ESCO wondering, when should I be worried that my symptoms are more than irritable bowel syndrome?
Oh, sure. Part of it depends on how long the symptoms have been there and what the symptoms are. And so whenever someone's above the age of 50, we tend to not diagnose irritable bowel syndrome without a more thorough workup. Mm-hmm. Also, if the symptoms include bleeding into the GI tract or severe abdominal pain, those are more alarming symptoms. Weight loss would be another one, or fevers or chills with the symptoms that this is probably not just your standard irritable bowel syndrome.
Thank you. Maybe I'll ask you a follow-up question, because another caller from Wisconsin likes to know, are there over-the-counter medications or things that can be taken for irritable bowel syndrome?
So sometimes we'll try things like fiber, soluble fiber that people can take. Certainly, depending on what symptoms are, some people with their irritable bowel syndrome tend to be more constipation predominant. Sometimes we do recommend medications like Miralax or other stool softeners or laxatives. So it really just depends on what the symptoms are. But again, you know, it's probably something that you'd want to meet with your physician to discuss before treating on your own.
Thank you. Dr. Irwin, a caller from Duluth, wants to know, why do people with Barrett's esophagus have trouble swallowing?
Well,
or do they have trouble swallowing?
Not necessarily. If you have Barrett's esophagus and start to develop dysphagia or trouble swallowing, it's certainly something we want to take a look into. Just like any kind of irritation or reflux esophagitis, people can form strictures, rings, and things like that. But the really concerning feature there is, as you know, Barrett's is something that we watch closely for changes towards cancer or dysplasia. So if a patient has Barrett's and they've suddenly developed issues swallowing, it's something we need to take a close look at to make sure that there hasn't been any malignant changes there.
How do you know if you have Barrett's?
Well, you really have to take a look. It's really a pathologic diagnosis. I mean, there's a certain endoscopic appearance to Barrett's that makes you believe that the patient has it, but ultimately when we take biopsies, they're going to tell us that there's goblet cell metaplasia present. So, yeah.
Thank you. Dr. McKee, caller from Duluth would like to know, what are the long-term implications of total large intestine removal, or removing the colon?
Wow, that's a big question. Well, first of all, you can survive nicely without your large intestine. I assume by that question they mean removing the whole large intestine and the rectum, and that they have an ileostomy meaning that the small intestine is brought out and that they're defecating into a pouch. In terms of nutritional status, you can maintain good nutrition. There's some risk for dehydration, so folks who are missing their large intestine have to be cognizant of that and pay attention to adequate fluid intake. But in terms of nutrition, it isn't a problem. You can maintain nutritional status without too much difficulty. So it's really more of a change in terms of how you're passing your waste, but from a health standpoint, it's not a real concern.
Very good, thank you. Dr. Thackeray, a caller from Duluth would like to know, since we talked about diverticulitis, what foods should you avoid and what foods are good to help prevent the problems from it?
Oh, sure. A lot of people have heard that we tell them to avoid things like nuts, berries, things that we thought in the past could get stuck in those little diverticula. But actually what we found out is that people who ate popcorn did better, and so we think it's more of a fiber issue. Yeah. And so we think of a high fiber diet being able to make the stool stick together, and so it's less likely to get stuck in those little outpouchings. And so typically once someone's had diverticulitis, we do recommend going on a high fiber diet or fiber supplement.
Great. Thank you. Dr. Irwin, a caller from Duluth would like to know, what's the purpose of the 3-hour breath test for irritable bowel syndrome?
Okay. There's a couple of applications there. I think probably what they're referring to is trying to rule out things like bacterial overgrowth. And it's a test basically designed where we'll give a sugar-type substance. The patient will drink it. If there's a significant number of bacteria in the small intestine, they'll take that sugar, metabolize it, and excrete gas, which can then be detected in the breath. If there's a certain peak at a certain time, and the interpretation of the test is very important, then it could suggest that there's too many bacteria in the small bowel, which could lead to diarrhea, malabsorption, etc., and then be treated with antibiotics.
Thank you. Dr. McKee, there's a tough question here, but a caller from Cloquet would like to know, what is fecal incontinence and what's the treatment for it?
Well, fecal incontinence is passing stool when you don't intend to pass stool, so it's basically loss of control of your bowels. And in terms of treatment, boy, we could talk all night about that. It depends really on the severity of the symptoms. If they're relatively mild, it could be as simple as using a bulking agent such as a fiber supplement and perhaps combining that with an antidiarrheal agent like Imodium if the stools are soft, and for mild incontinence that's frequently all you need to do. If it's more severe and doesn't respond to those minor sorts of treatments, there are a number of things that you can do. Biofeedback is sometimes used. There are injection treatments where a kind of polymer could be injected in the lower rectum perianal area, and in really severe cases, surgery.
It's a fairly common problem?
It's fairly common, especially in the elderly.
Yeah, thank you. Dr. Thackeray, well, there's two parts question here. Let's take part 2 here. What causes pain, abdominal pain, after eating?
So that's another big question. There's several things that can. Most of the GI tract, when it gets distended, that's where the pain receptors come into play. And so it can be that from distension somewhere in the GI tract that it's causing pain, would be the short answer.
Thank you. Dr. Irwin, is there a chance of remission of diverticulosis? Once you have it, do you always have it?
Pretty much. It's not going to regress necessarily. Those pouches have formed. And
do they cause any, I mean, other than diverticulitis? I mean, if you have the pouches, though, they don't necessarily cause you any problems,
No,
right?
not at all.
You
not
can
at all.
live a normal
You can
life.
live a normal life, and it's very common. We encounter it in our screening colonoscopies all the time, and patients are oftentimes surprised to hear that they have it. So, but, yeah.
Dr. McKee, a caller is wondering about after polyps are taken out of the colon, Is there scar tissue that forms? Does that ever cause any problems?
The scar tissue that ultimately forms doesn't really cause problems. There can be problems that form soon after taking out a polyp. There's a risk of bleeding. When you take out a polyp, a wound forms, a small ulcer can form, and there can be bleeding from that sometime in the first 2 weeks generally. So there's a risk of bleeding from that site as things are healing. But in terms of after the ultimate healing takes place and there is a little bit of scar tissue there, no, that's fine and doesn't cause any sort of problem.
Thank you. Dr. Thackeray, I'll get back to the same caller now. Not question number one of that, which these are good questions actually. Why do people vomit during endoscopy?
During endoscopy?
Or right after endoscopy? Or
usually, well, probably two reasons. One is that we give the patient medications to make them sleepy or comfortable.
Sure.
And so sometimes those medications can cause some upset stomach. The other is in order to see we're putting in a good amount of air. And so just that distension in that air can sometimes make people vomit, or they may feel more gassy during that day.
Okay. Well, thank you. Dr. Irwin, I'm going to ask you a question patients ask me all the time. And even some of my partners ask me all. Okay, now about colonoscopies, is there some new type of prep that's easier than the old prep?
Yeah, there's lots.
They're always talking about it.
Yeah, this is a subject near and dear to all our hearts because prep's probably the most important part of the whole thing, because without a good prep, the test really isn't all that good. There's been several newer preps, let's say, they've been out for a while, that are called low volume preps. I don't want to plug a particular company or anything, but there's one that involves 2 16-ounce glasses of fluid, which is a lot easier to take. There's other ones that involve 2 1-liter preps. There are pills that you can take in lieu of drinking a lot of liquid. But the one thing I really emphasize to my patients is that if you're not going to take the traditional gallon of Go Lightly, you need to drink plenty of clear fluids in addition to your prep. And generally, I think most of us probably split our preps into 2 anyways. So we take 1 part earlier in the evening and 1 part later in the evening, and it kind of depends on when you're going to come in for your colonoscopy. So in between those 2 preps, it's absolutely key to drink plenty of clear fluids, and that will work along with that prep to make sure you get a good prep. And that makes our job not just easier, but much better for the patient, so we can see inside that colon and tell them that we've got a good exam, and that's what they're there for.
Does each gastroenterologist have their own prep that they like or they want, or is it standardized?
No, it's not really standardized. I don't know how you guys do it in your practices, but we do offer a choice, and part of that choice is based on what the patient's insurance is going to pay for. So I try to give them an option. So.
Yeah. Oh, thank you. Wow, something I always wondered about. Okay, let's talk about, a caller from Moose Lake was wondering about constipation. What is the treatment for constipation? I mean, what can be done?
Well, there are a lot of possible treatments for constipation. I think first you have to try to explore what the underlying cause might be, because there are many possible things that could be causing constipation. It could be related to a patient's medications. It could be related to a coexisting disease such as diabetes or hypothyroidism. So if you can identify a condition that's contributing or causing the constipation, then treating that is obviously what you want to do first. If there isn't, if they're just constipated, then there are a number of different medications and treatments that you could look at, but there isn't really a one-size-fits-all answer, like everybody gets treated with medicine A, B, or C for constipation. It would depend on their age and health and other illnesses and the severity of the constipation. So I don't think I can say the treatment for constipation is to take this or do that. Being on a high-fiber diet is generally helpful. Taking in lots of fluids and if possible, increasing level of physical activity, exercise. All those are things that will work or at least help everybody. And then otherwise, it has to be individualized to the particular patient.
Great, thank you. Dr. Thackeray, here's a common problem. A caller from Virginia would like to know what causes a hiatal hernia.
A hiatal hernia? Well, it is extremely common, and there's a hole in the diaphragm where the esophagus enters into the abdomen, and the stomach gets pulled up through that, so essentially some of the stomach is up in the chest. The exact reason why, because it's so common, we don't usually know, but it's that hole that's naturally there just becomes a little bit bigger and lets some of that stomach come up.
And can you have a hiatal hernia and not have any symptoms?
Yes, yep, it's extremely common when we do upper endoscopies that we see hiatal hernias that are quite small and asymptomatic.
Okay. Thank you. Dr. Irwin, a caller from the Iron Range would like to know about probiotics. Does that help irritable bowel? Is there any connection there?
Well, there's a lot of conflicting literature on that one. I'll give you my personal experiences. I have been a little bit disappointed in probiotics in terms of controlling symptoms of irritable bowel. The idea behind it is to repopulate normal flora. If that contributed to your symptoms, if there was some reason why, perhaps antibiotic use that led to diarrhea and whatnot, it's possible that the probiotics could help with symptoms. But overall, I'm not a huge endorser of probiotics. I don't know about my colleagues, but.
Thank you. Caller from Dr. McKee, a caller from Chisholm would like to know: is H. pylori contagious?
Well, is H. pylori contagious? It's thought to be spread by the fecal-oral route. So yes, it's contagious. I mean, it's spread from person to person. Is it highly contagious? No. With good hygiene, hand washing and such, it's not going to be spread easily. But yes, it is contagious, and we certainly see that if one family member has it, it's more likely to be present in other family members. So yes, it can be spread from person to person, and that's how it is transmitted. So yes, it is contagious, but not highly so.
Thank you. Dr. Thackeray, a caller from Duluth would like to know: is virtual colonoscopy as good as the regular colonoscopy?
So we may be a little bit biased since we do colonoscopy, but CT or virtual colonography has come a long way. There's some patients where we might recommend that, but the advantage of doing a traditional colonoscopy over a virtual CT colonography is that if we find polyps, we can remove them right there. If something's found during a CT scan, we then have to still take the patient over to a colonoscopy and do it and take out the polyp, and the patient still have to prep.
So the prep is the same?
The prep is the same.
Oh, darn. Okay. Let me ask this question just for general purposes. So who should have a colonoscopy for screening purposes?
Well,
what's the recommendation?
Recommendation is everybody gets a screening colonoscopy at age 50 at the very least. And then it comes down to family history. If you have a first-degree relative, you should probably begin your screening colonoscopies 10 years earlier than when they were diagnosed, the age they were diagnosed. And that's kind of the rough guidelines. There are a few other health conditions that might lead you to get an earlier colonoscopy as well.
Okay. Well, thank you. Dr. McKee, there's actually a question for you. Somebody called in from Duluth. Why do people with a stomach wrap for GERD or Barrett's esophagus, why can't they vomit or burp?
Well, it's an interesting question. First of all, just to back up a little bit to explain to the audience, the stomach wrap is an operation done for people who have refractory reflux symptoms. And what is done is the upper part of the stomach is literally wrapped around the lower part of the esophagus and sewn into that position by the surgeon. And basically, the surgery is done to create a sort of a partial blockage and to keep acid and other contents in the stomach from being able to come up easily in the esophagus, up into the esophagus. And if those sorts of things can't come up, well, at the same time, neither can you vomit. I mean, you can't have it both ways. And so if you can't reflux, you can't vomit either.
Very good. Well, thank you. Well, let's see. We're getting near the end of our show here tonight. So I'd like to thank our panelists, Dr. Bradley Irwin, Dr. Daniel McKee, Dr. Aaron Thackeray, and our medical students, Derek Anders, Paige Nelson, and Melody Shepard. Next week, please join Dr. Ruth Westra for a program on lung problems, when our panelists will be Dr. Mary Boylan, Dr. Wayne Elmore, and Dr. Jake Powell. Thank you for watching, and good night.